Tēnā koutou katoa, ko Gina O'Grady tōko ingoa. Thank you for the invitation to speak. I haven't spoken to this many people for a long time. Our paediatric neurology meetings are definitely not this big. So I've got the very big task of talking to you for 10 minutes on epilepsy in children, so we'll get started. So I just wanted to start with some basic definitions. So what we just call an epileptic seizure. So an epileptic seizure is a transient occurrence of signs or symptoms, and the key thing is that it's due to abnormal excessive neuronal activity in the brain, so really differentiating it from a non-epileptic event. And so the classification, the terminology for, it's even tough as a neurologist to keep up with the changing terminology for classification of seizures. They're now classified according to whether the seizure is focal in onset or generalized in onset, or sometimes you don't know. Then within the group of focal onset seizures, we think about whether the child's awareness is maintained or whether they have impaired awareness. So this is sort of the old partial seizure, and complex partial seizure is now a focal onset seizure with impaired awareness. Or with retained awareness. And we then think about whether the focal seizure is motor in onset or non-motor in onset. And generalized seizures can also be classified as whether they are motor seizures or whether they're a non-motor seizure, such as an absence seizure. And so families still come to us and say, well, does my child have epilepsy? And so epilepsy is a tendency towards recurrent seizures. So that's any child who's had 2 unprovoked seizures occurring more than 24 hours apart, or it can be a child who's had a single unprovoked seizure and has a probability of further epileptic seizures, and so we might be getting that information perhaps based on their EEG result. Or it can be a child who's had a diagnosis of an epilepsy syndrome. And so what is an epilepsy syndrome? So an epilepsy syndrome is a characteristic cluster of clinical and EEG features, often supported by specific etiological findings. And so they're grouped according to age of onset, and the ones that are the more common ones that you'll be familiar with are things like childhood absence epilepsy or self-limited epilepsy with centrotemporal spikes, which was called benign Rolandic epilepsy. And so where we can, if we can make an epilepsy syndromic diagnosis, it helps to provide etiological information. It can guide investigations. So, a child who's got really typical childhood absence epilepsy doesn't need to have an MRI. It provides prognosis for families. So, what is that child's chance of growing out of their seizures in their lifetime or over their childhood years? And helps us to guide management. So our selection of anti-seizure medications, is very much based on seizure type and epilepsy syndrome. So moving on to a child who has a suspected first seizure, the things that you're really thinking about is, is this an event an epileptic seizure? And so it's important to consider non-epileptic differentials. So was it an epileptic seizure, or could it have been a faint, a breath-holding spell? Could it have been a cardiac event or just a daydreaming event? And then thinking about the etiology. And so really trying to exclude an acute symptomatic seizure, so where the child has some sort of underlying cause for their seizure, and going through your kind of surgical sieve type approach. It could be infectious, metabolic, toxic, structural. And so the things that are going to help you make those decisions and differentials are your history. And so history is key, really. So you want a really detailed description of events. What was the child doing at the onset of the event? Were there any focal features during the event? Did they have retained awareness, altered awareness? Where did the event occur? Was it during sports? Was it at nighttime, daytime, from rest? How long did it last for? How did it end? And what was the child like after the event? Were they drowsy? Did they recover immediately to their usual self? Video is really helpful. Most families wouldn't usually record the first event, but certainly going forward, that's something that you can encourage families to do. Is there a prior history of seizures? So sort of in retrospect, was perhaps the child having some steering spells that the family hadn't recognised? Is there a family history? And so I guess the red flags are, past history of epilepsy, sudden death, particularly in childhood or teenage years, or arrhythmic disorders. And then developmental history. So where is that infant or child up to with their development? Have they lost any skills? And so an accurate history of events is the most important thing in trying to determine a patient's seizure type. So in the health pathways, there is more detail there in the examination section, but a lot of these features are sort of thinking about, acute symptomatic seizure and underlying cause. We want all children who've had a seizure or suspected seizure to have an ECG. Obviously, if the seizure is ongoing, you're thinking about things like blood glucose. Some of your other investigations are going to depend on the circumstances. And so neuroimaging is something that the paediatrician would be considering, and we would be thinking about that particularly if there was any focal deficits, someone who'd had a head trauma or first status epilepticus. And so then hopefully with that history and investigations, you're coming to a formulation in your own mind about the diagnosis. Was this a febrile seizure? And so Sue's going to talk about febrile seizures next. Is this an acute symptomatic seizure? Is this a single epileptic seizure? Can you make a diagnosis of epilepsy based on the seizure type, the epilepsy type? Can you make an epilepsy syndromic diagnosis? Or was this a non-epileptic event? So the things that we'd be looking for after a first febrile seizure, that the child and the family are provided with seizure education and information about first aid, and we'll talk about this a little bit more. And then referral for review by a paediatrician. And so within 2 weeks is sort of the recommended based on our New Zealand guidelines, and obviously, based on resources might not always be achievable. So it's really important, and we'll go through the red flags, that if there are any acute features of concern, that child gets referred urgently for review. In New Zealand, we then want paediatricians for anyone who's had a suspected first seizure to be referring for a sleep-deprived EEG. Anti-seizure medication wouldn't usually be commenced after a first seizure. There are some exceptions to that. But you might consider providing a family with education about emergency or rescue medicine. So what are the features of concern that should be prompting sort of an urgent referral to a paediatrician? So a child who's aged under 2 years when they have their first seizure, any seizure that's lasted for more than 5 minutes, anyone who's had recurrent seizures within 24 hours, someone who's having extremely frequent seizures. And so some of the kids presenting with childhood absence epilepsy can really end up with 50, 100 seizures per day. So we don't want them sitting waiting for review. Particularly if there's any regression of development with onset of seizures, or if the child's unwell with features suggesting a metabolic abnormality, toxins, drugs, acute cerebral pathology, or encephalopathic features, and I'll talk a little bit briefly about epileptic spasms. Abnormal ECG, particularly long QT, or persistent onset focal neurological signs or symptoms once the seisure's resolved, or if there's concern about an unexplained injury and possible non-accidental injury. So education after a first seizure, you'd be explaining what a seizure is and what your preliminary diagnosis is, talking about a risk of recurrence, and then what the family should do in that situation. And so it's really lying the child on the floor, making sure that they're safe, don't need to put anything into their mouth or do anything to their tongue, phoning the ambulance if the seizure lasts for more than 5 minutes, and putting the child into the recovery position during the postictal period. And so these are 2 good websites which have got lots of resources that you can use to pass on to families. So the Kids Health website, and then the Starship Paediatric Neurology Clinical Network. So after a first seizure, the education, important to families to be particularly cautious around water. So drowning is the most common cause of death caused by a seizure. So we talk to families about showering their child instead of bathing. And if they're swimming, they need one-on-one supervision by an adult who's aware of their epilepsy. We caution about riding the bike, particularly around traffic, or climbing more than a metre off the ground unless there's a soft playground surface under it. It's important the family know who to contact, so that if there are a lot more seizures in the time that they're waiting for that paediatric review, that they do come back and see you. And video are really helpful for us, so that if families come to their appointments with some videos of the event, it can really help to identify the seizure type. So rescue medicine we'd think about in somebody who's older than 3 months of age, who's had a prolonged seizure, and we'd prescribe buccal midazolam in the plastic ampules. Epilepsy New Zealand is a great resource. They've got field workers who can go out and do education with families, also education in the preschool or school setting. And so 1 minute to talk about epileptic encephalopathy. So this is where the seizures or the interictal EEG negatively impact on development. And I really just wanted to show you this one video of a seizure because infantile spasms are one of the seizure types that really can catch out people who are not familiar with them. If I can play it for you. Oh, here we go. So it's sort of most common in children who are sort of between perhaps 3 and 9 months of age, that first year of life. And so it looks like a little series of kind of crunchies. So the baby either puts their arms out to the side or maybe sort of flexes forward. There's often a little up roll of the eyes with it. And they do it again and again at that sort of frequency. So one, another one. And so the baby is, aware during it. Some babies will sort of start to get a little bit irritable whilst the seizure is ongoing. And, if a family came and told you they were doing that without a video, it would be really hard. And so families will often get reassured that this is sort of colic. But once you've seen the video, and hopefully from having seen a video before, that this is something that you will recognise in the future. And this really needs an urgent referral to paediatricians. So anyone who is looking for more education about epilepsy, our PET 1 course that we run around the country is a really good one for sort of community providers, GPs, practice nurses. PET 2 and PET 3 are a little bit more oriented towards paediatricians, but would be appropriate for anybody who wanted to learn more about epilepsy. If you really want more details, there's an epilepsy guideline available from the Starship website. Thank you. Epilepsy in 10 minutes.